and welcome to Hadassah On Call, New Frontiers in Medicine. I'm your host, Mayan Hoffman. Today, we're going to discuss diseases related to the gastrointestinal tract. Crohn's disease inflames the lining of the GI tract and disrupts your body's ability to digest food, absorb nutrition, and healthily eliminate waste. Many American Jews know about this disease because they are prone to having it. The symptoms: intense abdominal pain, fatigue, severe diarrhea, weight loss, and malnutrition. According to experts, Crohn's disease is 2 to 4 times more prevalent among people of Ashkenazic ancestry than non-Jewish European ancestry. The reason is that the Ashkenazi population has been insular, meaning that by sticking together and marrying each other, there is no genetic makeup that is unique to the Ashkenazi population. But it also means that there are higher recurrences of certain diseases. Besides Crohn's disease, other diseases tend to show themselves more among Ashkenazi than for everyone else. For example, Tay-Sachs disease, Gaucher disease, Bloom syndrome, and others. Today, we have 2 Hadassah experts with us to discuss Crohn's disease and 2 other gut diseases, irritable bowel syndrome and, God forbid, colon cancer. I want to introduce gastroenterologist Dr. Ari Benson and pediatric gastroenterologist Dr. Zev Davidovics, both of Hadassah Medical Organization. Welcome, Dr. Benson and Dr. Davidovics.
Hey, thank you. Thanks for having us.
Yeah, it's great to be with you. So, I want to just jump right into some of the challenges that people might have with Crohn's, colitis, colon cancer, all of which we're going to learn, I think, later today are somewhat connected or can be connected. So let's just start with a scenario. You've been having severe diarrhea, abdominal pain, and you notice that over time it's leading to weight loss. Maybe you're not having the same cravings. Do you think that you have Crohn's disease? Could something be going wrong? What should you do?
So I think that those are symptoms that should definitely be examined with a physician. Once you start having weight loss, it's definitely a warning sign or a red flag that it should be investigated and that perhaps certain tests should be performed. Once that's combined with, I think you said diarrhea and abdominal pain, it kind of maybe directs the evaluation to the GI tract or the gastrointestinal tract. And Crohn's disease is definitely one of the diseases that can present with those symptoms. But again, throughout the evaluation, either through blood tests or stool tests or imaging studies such as a CT scan, we can then, look further into these symptoms to try to figure out what the cause might be.
Are there other symptoms other than the few that I named, the nausea or the diarrhea, those kind of things?
So I think along with diarrhea and weight loss, it's not just any diarrhea, but possibly bloody diarrhea is a particular red flag or warning sign, both for IBD and possibly colon cancer or some other disease. So that's definitely something that I would look out for or seek medical care if you're experiencing that.
Is Crohn's disease hereditary or is something you develop from, stress or something else?
So, great question. So first, just to go back, talk about kids. So aside from weight loss in kids, one of the red flags can actually be poor weight gain or poor growth. So those are other factors to think about in kids that are different than adults. In terms of risk factors, so it's having a family member with Crohn's or colitis or IBD, you have a 10% increased risk of developing Crohn's or colitis throughout your lifetime. So there is an increase. There's a familial component, but it's not entirely familial.
So are there other populations or certain populations, I guess, that we should be looking at if it's not all hereditary?
For sure, it's more common among Ashkenazi Jews. That's known. It's also, interestingly and not clearly known why, but the farther you are away from the equator, the higher risk you have for developing
Geographically.
Why that happens, unclear. Possibly like the sun exposure, vitamin D. There's some theories about why, not clear exactly why. But those are the populations that generally either Jewish or farther from the equator. It seems to be.
Do we know why it's so hereditary in the Jewish community, why Ashkenazim tends to have more?
Great question. Again, there's no specific gene that we've discovered that relates specifically to causing Crohn's or colitis. What causes it, again, is unclear. There's thought to be some familial component, not specifically genetic that we can identify, but familial, possibly related to autoimmune, where the body begins to attack itself for some unclear reason, possibly related to diet, possibly related to the bacterial makeup of our intestine, all those playing a role together, causing inflammation that goes unchecked, causing the disease. Exactly why Jews are more prone to it, unclear. But once it becomes familial, it stays that way, and Jews tend to stay with Jews.
What about men versus women? Are there more men or more women who get the disease?
I don't think that there's a real difference in the percentage of men versus women who get the disease. There are, of course, certain aspects of IBD or inflammatory bowel disease and differences between men and women, most importantly being pregnancy and fertility. If you have active inflammation, either because of Crohn's disease, the inflammation in your intestines, or ulcerative colitis, it can definitely affect fertility and pregnancy. So you definitely want to ensure that you're under adequate treatment before, entering pregnancy. And then there might be some hormonal connection that either relate to the menstrual cycle that could impact flares of IBD.
It's interesting. Because, in children versus adults, it also shows up different, correct? What would be the difference? You can take that first in terms of how one would see it in a child versus what one would see in an adult.
So again, back to the growth. So it affects both our treatment and how aggressive we are in treatment, because it can affect growth. So if we're not aggressive enough in treatment, it can affect future growth and future outcomes. That's very important in terms of guiding our treatments. In terms of, what's the second part of the question?
What it looks like in adults. That might be different.
There are some small differences on how it presents in kids. It's more commonly affecting the entire colon and end of the small intestine in kids than adults. So it can present initially a little differently. Management and course, though, has become quite similar between the groups.
Yeah, no, I think in the same way that it's poor growth in children, the weight loss can kind of be a comparison to the poor growth. So that if you're losing weight, it could be a sign of some sort of inflammation or Crohn's disease. Again, the initial peak in the adult population might be somewhere between 15 and 35, but we see new diagnoses throughout the lifespan of adults.
So in other words, people are generally diagnosed between those ages, but they could be diagnosed earlier or later, depending, and it's not no rhyme or reason to that. So is Crohn's actually, you mentioned an autoimmune disease, is Crohn's considered an autoimmune disease?
So again, there's thought to be an autoimmune component to it, because you have inflammation that goes unchecked for no clear reason, where the body, we think, begins attacking itself, essentially, and causing this inflammation that shouldn't be there. So the body purposely creates inflammation to fight infection, other diseases. But here, there's inflammation that really has no clear purpose that we see except causing this damage to the intestines that then causes symptoms. So in that sense, you can call it autoimmune, but it's not the only component. There seems, again, to be some familial components, some additional factors that play a role. Maybe, again, the microbiome, the bacteria that are there, maybe diet plays a role.
But autoimmune diseases tend to be incurable. So is Crohn's incurable?
So Crohn's disease is thought to be a lifelong disease. There are medications that work really well to have our children and adults in what we call clinical remission, where basically the symptoms are controlled. And sometimes you can even try to come off of medication and switch to diet as a treatment. That's a whole separate category of how the disease can actually be treated in some cases with diet. But it's thought to be a lifelong chronic disease.
Now, you've mentioned the terminology IBD several times in this conversation, which I understand stands for inflammatory bowel disease, which is not to be confused with irritable bowel syndrome. Is that right? So explain to me the difference between these two and why you think people might sometimes get this confused.
So inflammatory bowel disease is the disease that includes Crohn's disease, ulcerative colitis, and a few other small inflammatory diseases where we actually see in the GI tract evidence of inflammation. It could be ulcers, it could be erosions. We actually see the damage that is caused. And that's why it's considered autoimmune disease or a strong autoimmune component. Irritable bowel syndrome is what's considered a disorder related to the gut-brain axis. And it's not necessarily something that we can see with our own eyes. It can cause severe symptoms, and there are multiple different treatments for it, but it's not a disease that's considered to be inflammation of the GI tract. And I think that's the important difference between IBD and IBS, whereas IBD is related to inflammation that we can actually see both in pictures and, endoscopy and in the microscope. But IBS is some sort of connection between the gut-brain axis.
Which is just an irritation in some ways, that's the irritable versus the inflammatory.
And the symptoms can be severe with IBS. So you can have patients, and we have this often, come in with maybe mild symptoms of pain, and you do a colonoscopy and you see that they have severe inflammation, but they're not complaining of pain. And the opposite is also true. With IBS, they can have severe debilitating pain, but no inflammation that we can see or diagnose specifically by doing colonoscopy.
And now with regards to Crohn's versus colitis, what's the difference between those?
So Crohn's disease is a disease that can affect anywhere from the mouth to the end of the colon. So you can have inflammation really from anywhere. Anywhere there's mucosa, it can be inflamed. More commonly, it affects the colon or the small intestine. Colitis, ulcerative colitis, just affects the colon. Those are the main differences. They have some other potential diseases that can go along with them, but those are the main differences between the two.
And with regards to, we talked a little bit about symptoms before and diagnosis, but when do you think that somebody should rush out and try to get a colonoscopy? If somebody starts to experience some of these symptoms, is that the first recourse? And if not, then what is?
I think the diagnosis of Crohn's disease or ulcerative colitis is a combination of multiple modalities. And that includes blood tests, stool tests, endoscopy, which is either colonoscopy or upper endoscopy, and imaging, CT or MRI. And colonoscopy is probably one of, if not the most important, because we can actually take biopsies. And then once we take biopsies, the pathologist can look and give you a microscopic diagnosis. So yes, I think if there are certain severe symptoms, a patient should seek out a colonoscopy, but it needs to be within the context of consulting with their physician to make sure that they're getting all the tests that are needed, and maybe not just the colonoscopy, but other tests as well.
And
that's from the adult standpoint.
Oh, is there something different?
No, from the kids, it's the same. I would just add the additional potential risk. The procedure is done under anesthesia. So with children, you're weighing in the additional risk factor of anesthesia when you're doing this procedure. So agreed, it's part of the diagnosis. And when you're concerned for inflammatory bowel disease, you're definitely doing a colonoscopy, as well as possibly an endoscopy from above. But you're weighing that and making sure you're doing the test for the appropriate reason.
Is there anything that can lead to a flare-up? We mentioned stress before, potentially diet. Here in Israel, I've heard the Mediterranean diet might be good for helping to manage Crohn's and colitis. Can you talk a little bit about that?
So for sure, stress can worsen symptoms. So in general, we discussed how the disease is a lifelong disease, and the medications we have work well to keep the disease calm. But there can be stresses in life that can make flares, where you have worsening symptoms of bleeding or stomach pain or cramping. Those flares can be triggered by infections or by emotional stresses or other stresses on yourself. So it's part of our treatment in pediatrics is actually a psychologist on our team that works with our patients regularly and helps them manage their stress to help decrease their symptoms. In terms of diet, there are several diets that are shown to improve at least initial healing with Crohn's disease. There's one called the Crohn's disease exclusion diet, which is a diet that's limited in many different foods that are thought to cause inflammation. Not specifically so much related to a Mediterranean diet. It's a diet that limits basically everything with a food stamp on it. So all processed food, dairy products, those are the main things that you're avoiding. And that seems to help improve symptoms in certain patients with IBD.
So there's been some studies recently I saw that have been linking the risk of cancer among patients that had pediatric onset IBD. Can that be avoided? Is that link a reality?
So it's a great question. So there are some recent papers that have shown that there is an increased risk when compared to the general population, about twice the risk of colon cancer among pediatric patients who've had inflammatory bowel disease. And this data, it's an old disease. The data is relatively new. The treatments have changed significantly over the past 20 to 30 years. 30 years ago, there was really 1 to 2 treatments. There was steroids, maybe Imuran, other medications. 20 years ago, the first biologic drug, which is a drug that was given via IV, started, called infliximab, which changed the landscape of how kids were treated and adults and changed the course of the disease. Over the past 5 years, there's been another handful of drugs that have come out that, again, are changing the course of the disease. So while looking back over 30 to 40 years, you do see that increased risk now. The data on how we better treat the disease now affects the future outcome. We don't know yet.
So in other words, while what was happening previously could be leading to cancer, it's possible that with the new treatments and the new management, in 30 years' time, we won't see that it's necessary.
That's the exact hope. And our goal is always to decrease inflammation. And we do follow-up colonoscopies even after diagnosis to make sure that there's no inflammation. And part of the surveillance among the adults is to keep on doing those screening colonoscopies to make sure there isn't cancer risk and inflammation as we continue to manage them.
And in general, how does colon cancer begin? I mean, is there any knowledge to how that is sparked?
That's a great question. And it's really unclear which specific people might develop colon cancer. There's obviously a hereditary component, and there are certain syndromes or genetic, aspects to it that can predispose someone or make someone very high risk for colon cancer. The relation to IBD is that the inflammation that exists in the colon can lead to a lot of let's say, worsening of narrowing of the colon that can then lead to colon cancer. So the more that we treat the inflammation and we reduce the impact of the inflammation, the lower the risk of the cancer. In terms of the general population, however, over the past several years, we've significantly increased screening for colon cancer. So a lot of the cancer that we find now are people who undergo screening, even that they're feeling completely well. So
That's important because isn't colon cancer very deadly if it gets to a later stage?
yeah, definitely. And not only is it important to detect it early, to provide treatment early, but we can also find precancerous lesions. So the polyps that will then later develop into cancer can be removed. So that's the important part of doing a colonoscopy, is not only to detect if something is there, but also to take it out before it can turn into cancer.
When we spoke about Crohn's and colitis, we were able to identify certain populations that tend to be more prone to it geographically. We talked about the Ashkenazi population. When we talk about colon cancer, is there something similar to that? Is there a cohort of people who's more prone to developing cancer?
As it relates to colon cancer, I don't think that there's any specific population that's higher risk, other than if you have a family history. If you have a family history of colon cancer, you need to be extra careful about screening and possibly do more intensive screening and possibly only do screening with colonoscopy. So in that sense, yes, there are certain populations that are higher risk, but it's more the familial or hereditary cancers.
So colon cancer is genetic or just...
There's definitely a genetic component to colon cancer. There are certain colon cancers that are related to genetics as opposed to just sporadic cancers that develop in individuals.
What does colon cancer look like when it first develops, and how does it change over time?
So because of screening, we're seeing earlier and earlier cancers. So most, or if not all, colon cancers start out as a polyp or a certain tiny growth within the colon. And over time, depending on if there is a familial or genetic component, it can grow more quickly or slowly. So initially, the cancer would start out as a polyp if it's not related to inflammation, and then develop into a cancer. We are now diagnosing colon cancer at various different stages, depending on if we're doing it during screening versus someone who did not undergo screening, or a person who had a missed cancer on screening and then later developed cancer. So sometimes we can see it very early on, and unfortunately, sometimes we see it when it's already spread and it's metastatic.
If you catch it early, does that make it treatable?
The earlier you catch it, it's definitely more treatable. First of all, you might be able to resect it endoscopically if it's a precancerous lesion, or you might be able to just have surgery without having any additional therapy if it hasn't spread to the lymph nodes or to the other distant organs. So the earlier you catch it, it's definitely the more important.
But when you say surgery, I mean, what kind of surgery do you do? Don't you need your colon?
So it's definitely better to have your colon, but if you have cancer in your colon, it's definitely more beneficial to have that removed. So you can also remove certain parts of the colon. If the cancer is in the sigmoid, for example, which is the part of the colon right before the very end, you can have that part removed, and that's removed by surgeons. So yes, there are definitely consequences to having parts of your colon removed, but if you have a cancer there, it's more important to get rid of that.
And what are other treatment options?
So definitely the primary treatment option is to resect it, to either have surgery. And again, if it's an early polyp that's precancerous or about to become cancer, we now have an option to resect it endoscopically, where it's a procedure where we dissect off the lesion from the colon, which can preserve the colon. These are for very early cancers or mostly precancerous lesions, because once it develops into a cancer, it's better to undergo surgery. Sometimes patients who have surgery still need to have chemotherapy or radiation, or sometimes, depending on genetic mutations, they can have targeted genetic therapy. So there are other options, but the most important option is to get rid of the primary tumor or the primary, cancer that was found.
Now, I know that here at Hadassah, you're doing some pretty groundbreaking work in terms of how you're treating and operating on these cancers. Can you talk about that?
So From a gastroenterologist perspective, we like to find these lesions before they've become metastatic, before they've spread, and before they've grown extensively. So, ideally, we would like to not find anything at all on the screening. But if we find something that's early cancer, or precancerous, we can do endoscopic submucosal dissection, which is an endoscopic procedure. It was actually developed in the East, in Japan, and we've been there to train. And what we do is we dissect off advanced polyps before they can develop into a more extensive cancer and spread. So that's a procedure that has been revolutionary to preserve organs of patients here. But again, I just want to emphasize, once it becomes cancer, it probably needs to have surgery. So these are more of the in-between lesions that maybe previously would have been taken out with surgery, but had not turned into cancer yet, but we can now remove endoscopically.
Now, going to more of the specialty in the pediatric side and with IBD, are there also special techniques that you're using or any kind of new research that you're doing in your department?
So the research that we focus on is primarily in the treatment side. So many of the drugs that are available in kids, unfortunately or unfortunately, the general population is made up of adults. And most drugs start with adults and eventually trickle down to kids. And to get approval for kids requires a good amount of research, a good amount of studies. So we're involved in many multi-center studies, evaluating a lot of these medications that we know have some effect in adults, because it's not ethical to try treatments on kids that we don't have some effect. And then we use them for kids. So we have several trials that are ongoing now using medications that are used in adults that we're now using in kids with variable effect. And the goal obviously is to be able to expand these medications to use for kids, because again, we have limited drugs available for kids. It's actually just basically 2 medications approved for children beyond the basic medications. 2 of the newer medications that are approved, while in adults there are between 5 and 10 at this point. And many kids require medications because often the medications they start with don't continue to work for them.
Is there anything else that either of you want to add that I didn't ask you, or you feel that our listeners should know that we didn't get to talk about?
One interesting study, it's not our study, it's actually the adults. We're doing an AI-related colonoscopy screening study.
So screening colonoscopy has obviously advanced significantly since it first began, I know, a few decades ago. But the gastroenterologists are now utilizing artificial intelligence to help us detect polyps. So this is more for the screening colonoscopies, although it is now advanced to other situations. But when we're doing a colonoscopy and we're examining the colon for polyps, we can now use the assistance of artificial intelligence computers to put boxes around areas where they think polyps might be. So we are actually helping evaluate an Israeli company that is developing a new AI platform to help us find polyps, basically, and remove them before they can then turn into cancer.
Wow. Anything else that you want to add? Okay, well, thank you both so much, both Dr. Benson and Dr. Davidovics. It was wonderful to have you on the show.
Thank you for having us.
Thank you for having us.